Now, and welcome to PETOS, everyone. We're excited that you were able to find us. We made an official room for PETOS since this is going so well in the Zoom format. We've decided to make it our official source for these PETOS offerings. This is education provided by Utah's EMS for Children in partnership with Primary Children's and Utah's Telehealth Network. So we all got together and brought this to you because we really want to get good pediatric information out to you. So please make sure that you put your email in to the chat when I ask for it. That will verify your presence, and then you'll get a certificate in your email for CME. Today, we are going to hear from Dr. Hill Stucklein, and he is the medical director for Mountain West Ambulance, as well as a U of U ER doc. He is an associate professor of pediatric emergency medicine, and he is also an associate medical director for Salt Lake Fire. So his face may be very familiar to many of you. And we are excited to have him. I'm gonna turn it right over to him and let him share his screen.
Cool, thanks, Tia. Okay. I'm assuming everyone can see that okay. If not, wave your hands and yell. So today we're going to talk about pediatric out-of-hospital cardiac arrest. And I'm going to approach this by kind of comparing practices between adult and pediatric cardiac arrest. I'm also going to address things generally outside the context of COVID. There have been a number of changes to resuscitation practices during the COVID pandemic, including specifically airway management decisions, kind of duration of resuscitation, and use of mechanical CPR, which isn't as big an issue in kids, obviously. But I'm going to discuss things kind of from a pre-COVID perspective, although I know that may be folly since it's possible that we never really return to pre-COVID practices in their entirety. But I just wanted to make sure y'all knew kind of where I was coming from the beginning. So I want to start with a case, and then I'm going to put some friends on the spot. So take a second to read this, but basically 4-year-old with a history of some chronic processes, including seizures, who has a trach found unresponsive. EMS arrives on scene 5 minutes later. The mother's doing chest compressions after good pre-arrival instructions from dispatch, and the crew notes asystole on the monitor. Crews provide good care. They suction the trach and are able to ventilate appropriately through it with the bag valve mask, although I guess not the mask part. High quality CPR is done, no rhythm changes for 10 minutes, and the crew calls in asking what to do next. I know that Dr. Hughes and Dr. Pugh are on the call. So I'll start by asking Dr. Hughes, if the crew asks you what to do next, what would you tell them in this case?
So I think I would try to get a sense if mom had, they would have already done this, had any idea what triggered this event. Was the trach out? Was the child seizing with her metabolic disorder? Does she often get hypoglycemic or hyponatremic? Is there something that maybe is correctable, especially the electrolytes? And then I try to get a sense of mom's expectations. And I'm sure the crew's already approached this, but is this child with a complex history, is she DNR, or does mom have certain wishes or expectations for her? And I think my opinion is every cardiac arrest is different, especially in peds. And this one being in a home, I think lends itself to maybe being a place where you could call this a little bit more easily, where the family's there with the child in a private setting. This is an experienced medical family that might be able to understand what you're saying when you're giving them news of what's going on. So this would be a case where I would ask the crew if they feel comfortable talking to the parent about stopping resuscitation. If you've had asystole for 10 minutes plus an unknown downtime, the chance that this child's going to have a good outcome is pretty low. So I think this would be a case where I'd probably have the crew start approaching that with mom after they've determined there's no correctable things such as hypoglycemia.
Awesome. Those are all really important points and perspectives. I'll put Dr. Pugh on the spot. He gets the benefit of going second, though. Dr. Pugh's our EMS fellow at the university. So I'll ask Andrew, would you have any other thoughts, or would you approach this call any differently than Dr. Hughes did?
Yeah, it's definitely easy going after Dr. Hughes, but kind of my general approach would be obviously kind of good tenets of indirect medical control. So quickly identify myself to the caller, clarify the caller and who they are and their capabilities, and then just request some basic patient information, kind of who is the patient. Hopefully we've got a weight and things like that on the patient. Like Hillary said, kind of confirm we have IO access, and then think briefly about reversible causes. So I suspect this is most likely respiratory, but maybe not with this underlying metabolic disorder. So definitely checking a glucose, and maybe even recommending some IV normal saline or even hypertonic, given that if there's a history of hyponatremia, and that might be something that's difficult to tease out in the moment. And I think the question you're asking is whether to transport or stay on scene. And that's a tough question. Like Dr. Hughes said, this is a kid that has likely had a lot of contact and probably multiple admissions, and they might have a clear plan for a situation like this. And like Dr. Hughes said, broaching that with the family, I think, is highly appropriate. If this wasn't a medically complex child and this was very unexpected, I think my stance would be to recommend transport to the closest pediatric kind of capable facility. I've found that sometimes kind of is helpful for the parents, if nothing else, for the grieving process and things like that. But this is a more complex situation with a child with a trach and probably a history of multiple admissions. So I think that plays into it.
Awesome. Yeah, I appreciate all of those points too. And one other follow-up, and then I'll kind of get moving on. As part of Andrew's fellowship, he works both with Salt Lake Fire and with Mountain West. And for those of you that know the area and know where those two agencies operate, you know those are very different places. Andrew, do you think if this call came in both of those systems, that you would treat it differently, or do you think you'd be able to treat it the same in both systems?
You know, that's obviously a good question. I think this is obviously, well, this sounds like an atraumatic arrest. And I know that in pediatric trauma, where there's probably a reversible cause that warrants meeting one of the pediatric surgeons at primaries, this is someone I'd hope would be directly transferred to a pediatric receiving facility, like primary children's. But I don't know that there's a lot more to do besides uninterrupted CPR, management of the airway, correcting hypoxemia and correcting electrolyte imbalances. And I therefore think that I would transfer this patient to Mountain West for ongoing resuscitation, but I might be wrong, and there might be different thoughts.
No, I
agree with Andrew. And I just think, I also think it's up to the crew ultimately. You know, it's really, I have the privilege of being up on the hill at primary and all the support around me and social workers and child life and people to support the family. Whereas this might be two people on the scene with a distraught mother. And so I always support the crew if they feel like, gosh, I just can't, I can't take away everything right now in this room. I need to be at a hospital. I also always support that.
Awesome. Yeah, and I don't think there's any right or wrong answer to these questions that I'm asking. And I honestly wish I could have recordings of these answers and play little bits of them back as we go through this, because there were some really important things that were said. But good. I think that sets the stage well and kind of raises a lot of the questions that we're going to discuss. So with that, we'll move on. The first thing I want to show you all is that everyone is not doing things in the same way. Okay. This data is from the CARES registry, and it shows the significant variability among reporting systems in survival from out-of-hospital cardiac arrest. I don't think this is because the population in the cities on the left side are 10 times sicker or 10 times older than the populations in the systems on the right side of this. But what it does show is that there's variability in system protocols and system performance. The second thing I want to bring up is the idea of comfort with caring for pediatric patients. We're going to talk about aspects of care in pediatric and adult cardiac arrest that are different and similar. And I think we'll see that there are actually a lot of similarities, but it definitely doesn't feel like they're similar. This can be a rhetorical question, but how many of you would feel equally comfortable managing a pediatric cardiac arrest and an adult cardiac arrest? and why? I know my answer to that question is no way would I feel similarly comfortable. I think there are two big reasons. One is based in hard facts, and the other is absolutely not. The first is simple. We're naturally more comfortable with those things that we're more familiar with. First of all, on average in most EMS systems, pediatric calls make up somewhere around 10% of call volume, and an even smaller proportion of those calls then are for critical medical issues. Specifically regarding cardiac arrest, it happens much more frequently in adults than it does in children. Aside from the high rate in infants, which you see there, secondary in large part probably to SIDS, you can see that the incidence of cardiac arrest in older children is really low. Contrast that with adults, and you can see how much more common, more familiar we are with adults experiencing cardiac arrest. The second reason is a lot more complex, and that's emotion. And Hillary and Andrew both touched on this already. Anybody that's taken care of children and anyone who's cared for a child who hasn't survived knows how difficult it is emotionally. This challenge, I think, still plays a pretty big role in how we manage pediatric out-of-hospital cardiac arrest. I also want to say that while I make this distinction, I don't do it to minimize the emotion of caring for someone older who suffered from cardiac arrest and can't be resuscitated. It can be really, really difficult. But I think we would all have to agree that there's something different about children. So let's get into more details now. And I want to start by discussing what is the same about pediatric and adult cardiac arrest. Absolutely, without doubt, the most important thing we can do in treating cardiac arrest patients is provide high quality CPR as soon as possible and in as uninterrupted a fashion as possible. This infographic here obviously showing CPR in an adult, so the mechanics may be a little bit different in younger age groups, but the important components are the exact same. The right hand position, making sure you're providing quality compressions with full chest recoil and not leaning on the patient. Obviously, this is a little bit more of an issue with adults than with children when you're using, a two-hand encircling technique. But good compression depth, appropriate compression rate, with good in-the-moment feedback, either from other providers on scene or automated feedback devices if you have those. And then minimal interruptions, making sure that if you've got hands off for a pulse check or a rhythm check or a procedure or moving the patient, that you're doing verbal countdowns so that you avoid any unintended prolonged pauses. I know this is hopefully, something that's not new for anybody, that high quality CPR is what makes a difference in these patients. And that's no different whether it's a 90-year-old or a 9-year-old. Another component of cardiac arrest care that's similar between adults and children is the importance of preparation before arriving on scene. Recurring training and review of protocols, especially for these rare events, is critical. Once the call goes out, there's time on the way, usually, to discuss team roles and who will be doing what. The notion of pit crew CPR, where team members have specific roles and activities, and where things are highly choreographed, is one that is now pretty widely used, I think, that allows for protocolized implementation of interventions that hopefully mitigates the risk of confusion or forgetting things on scene. Reviewing roles and order of events before arrival can be really helpful. And then finally, for children in particular, using the Broslow tape or hand-Tevi app, and I should mention that I don't have any conflicts of interest regarding any of the content in this presentation, can be really important and can allow people to not only look up doses, but also potentially draw them up prior to arrival on scene and just have things even that little bit more prepared before you get there. So these are things that I think are very much the same between adults and kids. But how are things different? I will say that we have some data that easily show pretty obvious differences, but I also want to point out that there's far less high quality data on pediatric cardiac arrest than adult cardiac arrest. And that's not because there's not a lack of people who care about this topic. Cardiac arrest research is difficult, especially high quality randomized trials. Pre-hospital cardiac arrest research is even more difficult when you take into account the need for exception from informed consent for randomized trials. Then add on top of that the logistical and ethical challenges of research with minors. And I think it's really easy to see why data for pediatric cardiac arrest is a lot more limited than what we have for adults. So one big difference between kids and adults is the presenting rhythm. On the top, you see adults, and on the bottom, you see the distributions in different pediatric age ranges. While adolescents and teenagers have a pretty similar distribution of presenting rhythms, you can see, compared to adults, you can see that it's really quite different for newborns and infants in particular. And these differences are important because they reflect the differences in etiology of arrest and then what treatments, specifically defibrillation, for example, might make a difference for the patient. I don't think the information on this slide will be a surprise to anybody. This is data again from the CARES registry for 2019. And it shows the breakdown for etiology of arrest for adults on the left and pediatric patients on the right. And what's immediately noticeable is the much higher proportion of respiratory and drowning cases in children. We've already talked about the importance of high quality CPR and how this is no different whether you're treating a child or an adult. That's the cornerstone of good cardiac arrest care. But knowing how common a respiratory cause for arrest is in children, let's take a second to pause and we'll look at the evidence that we have guiding airway management in cardiac arrest. So for a long time, preferred airway management was different when comparing kids to adults, but management of adults may be moving in the direction of pediatrics a little bit more now. In 2018, JAMA published, I think at least 2 of these were in the same issue, maybe even all 3. But 3 really big randomized trials looking at airway management strategy in adult out-of-hospital cardiac arrest. 2 of these compared supraglottic device use to intubation, and 1 compared BVM to intubation. These trials are not without limitations, but when you consider them all together, they provide pretty robust evidence that intubation is not a better strategy for airway management in adults. We could talk for hours about why this might be and about how the specifics of each EMS system need to be taken into account when interpreting these results. But I think in general, there was a pretty big movement and pretty quickly away from early and routine intubation in the adult population after these trials were published. In contrast, we'll take a look at the high quality evidence we have in pediatric patients. And on the right there is the only real randomized trial in children that came out of LA in 2000. And it's still the landmark study on pediatric airway management in cardiac arrest. So almost 20 years old, and we haven't had a repeat of this. This showed no survival benefit to intubation when compared with BVM for all-cause pediatric out-of-hospital cardiac arrest. And it showed also a really high rate of unrecognized esophageal intubations and tube dislodgement. Now, this trial didn't look at the use of supraglottic devices, and it was performed before the widespread adoption of continuous capnography on every case of airway placement, which I think has probably been hammered into every pre-hospital provider and every ED provider at this point. But at the time this study was done, that was not the case. So the results of this same trial done now might look a little bit different 20 years later, but for the reasons we discussed earlier, it doesn't seem like this is going to happen anytime soon. There have been some observational trials supporting these findings, and AHA guidelines reflect this, stating that BVM is reasonable compared to advanced airway placement. The primary benefit to BVM is that it avoids potential pauses in CPR for advanced airway placement. An important caveat to this is that if you can't achieve adequate ventilation with BVM, which is definitely more of an issue with like the edentulous, obese, bearded adult than a child, then it's appropriate to put an advanced airway in that will facilitate adequate ventilation. So speaking about ventilation, we'll move on to that. Once you've made the decision to manage the airway, how are you supposed to assist with ventilation? I think 2 important ideas that are actually consistent between adults and kids are the importance of negative intrathoracic pressure and concerns over gastric distension. When we breathe under normal circumstances, it's negative pressure driving the process. But when we artificially deliver ventilations for someone, they're positive pressure breaths. And this can be a bad thing, especially if ventilation occurs too frequently. because that negative intrathoracic pressure is overcome, and it's that negative pressure that helps draw blood back into the heart to then be delivered with the next compression. So more positive pressure means less venous return, which means less cardiac output under already imperfect conditions of CPR, where at best we're delivering around 60% of normal cardiac output. So avoiding hyperventilation is critical in adult and kids. Gastric distension can also be a problem for multiple reasons. It can increase the risk of emesis, which is particularly problematic if BVM is your method of choice. It can also increase abdominal volume, which results in lower thoracic volumes for lung recruitment and oxygenation. And if abdominal distension gets bad enough, it can also decrease venous return by increasing your abdominal compartment pressures. And this is probably more likely to be an issue in kids than it would be in adults, just because of their small size. So these are two important principles, and I think are actually consistent across kids and adults. But a new big difference between kids and adults is this recent change to the AHA guidelines, which now recommends increasing the ventilatory rate in pediatric patients with an advanced airway to 20 to 30 breaths per minute. And there's controversy about this change, and if Dr. Hughes or Dr. Pugh wants to chime in, or anybody else wants to chime in with questions or comments, feel free. But I think it's probably most prudent, honestly, in my opinion, to adjust ventilatory rate for each patient based on factors like patient's height and weight, based on age, and based on presumed etiology of arrest, right? It's probably better to give a higher rate to a 1 or 2 year old with a presumed hypoxic arrest, and a much lower respiratory rate to a 16-year-old who collapsed on the basketball court. So I think, honestly, a movement away from like a one-size-fits-all algorithm for cardiac arrest is what we're going to continue to see in the future, not only regarding ventilation, but probably regarding lots of different things, with decisions kind of being more intricate and tailored to each person's specific circumstances.
Hill?
Hey, Hill, it's Hillary. I totally agree with you that it should be tailored per patient. And if you have a smaller kid, anyone needs 30 minutes, except maybe just initially to help blow down some of that CO2, get some of that acidosis down. Because I do think that kind of makes resuscitation harder when you're so acidotic. But I agree that if you've got a big 100-kilo 15-year-old, you don't need to be breathing 30 times a minute, even though it's a peds.
Yep.
We also had a question in the chat. When achieving ROSC, the majority of patients are in a comatose state with no airway control. Is it best to care for patients by placing an advanced airway for long-term airway management and protection? Wouldn't this optimize continuum of patient care when arriving at the hospital?
That's a good question. I think the answer is probably a little bit different depending on whether you're talking about doing that on scene and you're 2 minutes from an ED, or if you are 30 minutes from an ED in a more rural area, or if you are doing this in the ED or in the ICU. So I think I would probably give different answers to that question depending on where you are. I think you can achieve good monitoring of things like end-tidal CO2 without necessarily having an advanced airway in place, although that's more difficult for sure. And so having an advanced airway in does facilitate that. But you have to keep in mind the risks associated with placing an advanced airway. One of the big ones during resuscitation is pauses in CPR, which we want to avoid. But even that study from 2000, which again, the results may be different now with kind of better monitoring for things like tube displacement or esophageal placement, are things that you have to consider. And when we talk about advanced airway placement in the pre-hospital setting, I think we also would have to discuss how often people have the opportunity to perform one of those procedures. Heck, I work in an ED where we almost never see kids, and the next time I have to intubate a kid is not going to be a super comfortable situation for me, that's for sure, because it will have been a long time. And that's the case for, I think, almost all pre-hospital providers too. Managing or placing, an airway in an adult probably doesn't happen that often for many of you. And that's got to be fewer and further between for doing that same thing in kids. And so performing a procedure like that, that you're not comfortable with, not familiar with, haven't performed in a long time, is something where you have to weigh the risks and benefits, honestly. So I think there are a lot of things that go into answering that question.
And I also think in peds, especially the younger kids who maybe don't have the body habitus of a bigger person, you have the benefit of really being able to see chest rise well, and you're being successful in oxygenation and ventilation when you can see a little baby's chest rise and fall very easily versus someone who might have a lot more tissue or volume in there. So I think you can, I've seen some of the best gases on a kid arrive at the ED with kids who've been bag mask ventilated for 15 minutes en route, and they had a perfect gas on arrival, versus a kid who comes in and maybe had 3 attempts in the field, and they come in, they're still in the esophagus. And we know that all of us can be bad at this. So we had a kid the other day in the peds ED. It took 7 attempts to get this kid intubated. 7, and that's with pediatric providers who are supposed to be the experts at this. So we know it can be tough. So if you have good chest rise and you're not a very long distance from a hospital, I would agree that I think it's beneficial just to keep what's working, and then you can replace the airway on arrival.
Yeah, I think the same thing goes. I agree with you, Hillary. The same thing goes with the question of if a supraglottic device is placed in the field and then they come into the ED, should you replace that with an ET tube? And my answer to that is no, not necessarily, unless there's some sort of complication, you're not able to ventilate, or there's some problem using it. I mean, if you're able to demonstrate through good chest rise with BVM, or through good end tidal capnography with the supraglottic device, that you're doing the job that you need to do, then keep doing it. And if it's not broken, don't fix it. So that was a long answer, but all right, we'll move on to epinephrine. I'm not going to spend a ton of time on this. We know pretty reliably in adults and children that delays in administration of epinephrine are associated with worse outcomes. I think we can agree that ROSC is important, and you don't get survival without first getting ROSC. But in looking at which outcomes are most important, a neurologically devastated patient with a heartbeat isn't necessarily what we're aiming for. The benefits of epinephrine have mainly been seen with ROSC, and much less so with neurologically favorable survival. There was a huge study a couple of years ago in the adult population showing that, yes, you'll get more ROSC by giving epi, but you end up with more neurologically devastated survivors, which, it gets to some ethical questions, but I don't think that's what our goal is. And I think in general, there are a lot of questions that we still need to answer about how to effectively use epinephrine, including those I've listed here. I could spend hours discussing these questions, but I think it's fair to say that a discussion of the virtues and curses of epinephrine is not a simple one. So knowing that, we'll kind of skip forward unless someone wants to ask something specifically or interject here. So let's say after administering the right meds, managing the airway appropriately, and providing excellent CPR, that you see a rhythm change and a sudden increase in end tidal CO2 on the monitor. You check a pulse and you've got ROSC. That's a relief. You've got parents that are crying for joy next to you, smiling for the first time since you arrived. I don't know how many of you work in the ED at primaries or know the doctors there well, but if any of you know Dr. Drapkin, who works in the ED at primaries, he gives the best high fives, really aggressive high fives. And that's probably exactly what you want to do with your partner after getting ROSC, but it's not the time for a high five because the work is not over. The care that is provided after ROSC, I think, is just as important as everything leading up to that point. A big part of post-ROSC care is to protect the brain, which admittedly should be in the back of our minds throughout the entire resuscitation. We want to avoid those things that will cause secondary injury to the brain, both during the resuscitation and after. So those things are hypoxia, hypercapnia, hypotension, and hypoglycemia, probably especially in kids. Another important idea is taking a few minutes on scene after ROSC to prep a few things, which we'll get to in a minute. The rationale for this is that rearrest after ROSC is a really common phenomenon, and it's associated with worse outcomes, not surprisingly. You can see how common rearrest is in both children and adults, and that it often happens really quickly after ROSC. So taking a few minutes on scene allows you to do some stuff while monitoring for the possibility of rearrest excuse me, as opposed to having nothing prepared and being in the process of moving the stretcher into the ambulance when rearrest occurs, and then having to, you know, shuffle around and figure out what the heck you're doing all over again. More and more research is coming out pointing to the importance of the post-ROSC period, both out of hospital and in hospital. So having a good post-ROSC bundle is one way, I think, to make sure that you're treating the period after ROSC with intent instead of just relief. So this is a bundle of care that's designed for adults, admittedly, and interventions like placing a Lucas and obtaining an EKG are not applicable, except maybe in the older child, to all pediatric cases. But ensuring that you have all your I's dotted and your T's crossed before you begin transport is really important, because like we already looked at, we know that rearrest happens and it happens early. We also know that care on scene is probably better than care in the back of an ambulance. And I say probably, that's being generous. Then obviously remaining vigilant for vital sign changes, rhythm changes, and being ready to intervene if necessary is critical. You'll notice that targeted temperature management is not part of this post-ROSC bundle, based on the best available evidence. And I'll admit my knowledge of this in children is not as good as it is in adults. We know that targeted temperature management is good for the brain when it can be done in a controlled setting in an ICU, but we haven't figured out a good way to achieve this in the pre-hospital setting without causing negative side effects. Ideas like infusing cold saline have not worked out, although other mechanisms like inhaled cool mist are being studied and may show different results. But for now, targeted temperature management in the pre-hospital setting is not a thing, at least not that I'm aware of. Anybody have any questions? Tia, do you see anything in the chat before we move on? Okay. So up to now, it turns out really that a lot of cardiac arrest care is pretty darn similar between kids and adults, in my opinion. But let's talk about a topic that is not easy to talk about, and that's withholding and termination of resuscitation in the field, and something that we touched on in that kind of earlier case. These are universal termination of resuscitation criteria for adults for ALS and BLS care that were published and validated in the mid-2000s. We aren't going to go over them in detail, but take a second to look through them. One important criterion that's not included in these rules is duration of resuscitation, and we'll get to that shortly. But let's see how these compare to pediatric rules or guidelines for termination or withholding of resuscitation. And there they are. There is essentially nothing on as broad a scale as the adult criteria for children. Here is specifically what we have in the state of Utah in our kind of state protocol guidelines. The first two sections are straightforward and are the same for adult and pediatric protocols. But take a look at the last section, and it says transport all patients after a 15-minute period of on-scene resuscitation. This is what I want to explore a little bit more. I'm going to hit pause real quickly to address the issue of traumatic cardiac arrest. We do actually have guidelines for this, although they're getting close to a decade old for both pediatric and adult termination and withholding of resuscitation. So we'll take a look at some of the details. You can see that the first two criteria for adults and children are the same and are pretty straightforward. Injuries incompatible with life are decapitation, hemicorpectomy. Obvious signs of death include dependent lividity, rigor mortis, decomposition. That stuff is straightforward. Otherwise, for children, the recommendations for traumatic arrest include immediate transport, and I didn't write that up there, but the guidelines say immediate transport if signs of life were observed on scene prior to arrest and CPR was started within 5 minutes, or if the victim is hypothermic, or if the patient is a drowning or lightning strike victim, or if circumstances don't seem consistent with a traumatic cause for arrest. I don't want to get too far into the details of these, but I want to use these guidelines to address two important points and contrast them with practices for non-traumatic arrest. The first is that statement to initiate immediate transport. And the second is the inclusion of time criteria for how long a resuscitation should continue prior to termination. Now, I have to say that this isn't an entirely fair comparison in terms of the mandate to immediately transport. In cases of traumatic arrest, those interventions that are possibly going to make a difference, like blood and a trauma surgeon, are not available on scene. Or at least for blood, not without significant delay for arrival of the right flight team who's carrying them. Although whole blood on ambulances is happening more commonly in systems around the country, and we may see that more in Utah in the future. But immediate transport for traumatic arrests actually makes sense. But when should we initiate transport for non-traumatic pediatric arrests? This is adult data looking at scene time across multiple systems for patients transported without ROSC. And you can see the difference between the high and the low performers and how that seems to correlate with outcomes. This is similar data for children coming from the same Resuscitation Outcomes Consortium data. You can see in the table at the bottom that the group with scene times in the middle, so not less than 10 minutes, not more than 35 minutes, had the best outcomes, and this is visually depicted above. This data looks pretty similar to the adult data on the last slide. Unfortunately, they don't include data on how many cases were terminated in the field versus transported. They don't include data on resuscitation time during transport or additional time spent on resuscitation in the ED. So this is a limited snapshot of the full resuscitation period. And we don't know how many of these patients had care terminated on scene or how many were transported at these time intervals. On top of this, there are two potential pitfalls in interpreting these data, both from this slide and the previous one. The first is, well, the slide with the adult data was just patients that were transported, so it is a little bit different. But the first pitfall is in those kids with the shortest resuscitation times, it may be that there was prognostication bias at play, where those who were transported or had arrest terminated early, so either of those two possibilities before 10 minutes, we don't know exactly what happened at that 10-minute time point, were patients either with negative prognostic factors like prolonged downtime and asystole, and providers determined that these cases were highly unlikely to survive and therefore terminated early, or perhaps they had positive prognostic factors like they were a witnessed arrest with early CPR or an EMS witnessed arrest, and therefore were rapidly transported because of those potentially positive prognostic factors. Providers may have been exactly right in either of those cases, or they may have missed some patients who would have survived either with longer resuscitations or transported people too early with worse care in the ambulance, and they may have gotten better care by staying on scene. We will never really know that unless we did some sort of trial where providers said, okay, I want to terminate resuscitation, or I'm going to transport to the ED right now. And then he said, no, you're randomized. You need to stay on scene right now, and you're going to continue resuscitation until a certain time point, and then we compare outcomes among those groups. So in the absence of something like that, this data is kind of limited. The second pitfall is in the group with the longest resuscitations. We know that prolonged low flow time without ROSC is bad for survival, but more importantly, for neurologically intact survival. These numbers reflect the fact that you may get ROSC, but the likelihood of survival to discharge is much lower in these patients because it just took longer to get decent perfusion to the brain in them.
We do have a question, Hill. I think it's
Yeah.
on what the topic you're talking about. Do we need to worry about cerebral vasoconstriction in hyperventilation of PD patients in cardiac arrest in regards to reducing cerebral blood flow and volume of the brain?
Absolutely. Yeah. And that's why the importance of not hyperventilating is really critical and should be part of a post-ROSC bundle and should be part of care during arrest, right? We have these devices that we use in adults that I don't think are used in kids called impedance threshold devices that are supposed to help with that idea of negative intrathoracic pressure. But they also have these timing lights that blink every 6 seconds. And based on the studies that have been done to date that I'm aware of, we can't tell if the benefit of the ITD, which is minimal at best, is because of the negative intrathoracic pressure benefits, or just the fact that there's that timing light telling you don't bag too fast, don't hyperventilate, because we know that that has deleterious effects related to negative intrathoracic pressure. So yes, maintaining good end-tidal CO2 and avoiding those effects on the cerebral vasculature related to hyperventilation is really important, both during and after arrest. All right. So I would say that these numbers are actually pretty muddy. They may suggest that there's a sweet spot for time on scene, or they may simply be exactly what we would expect based on those things I brought up, prognostication bias, and the fact that patients who take longer to resuscitate are less likely to survive. So on the surface, these numbers support kind of a moderate duration, stay in play sort of strategy, but I think they're definitely limited. But this is a good segue into the next important point, which is overall duration of resuscitation. This image, again, is one that shows data for adults. Sometimes we just have better data for adults on a lot of these questions. There are a lot of studies that have been done presenting similar data, all of which propose slightly different cutoffs for when you're unlikely to gain additional survivors. But the point isn't necessarily to look at the specific numbers, but instead to realize two things. The first is that, again, one size does not fit all, and things like initial rhythm, as shown here, but also downtime prior to initiation of resuscitation and plenty of other things make a big difference in potential for survival. The second is that termination protocols make a lot more sense when objective guidance on duration of resuscitation is included. So I just kind of want to summarize the good and the bad of working an arrest on scene versus rapidly transporting. The downsides of transporting are the risks of lights and sirens transport, which isn't just for transport, that's for response to scene too. We know that the risk for providers, patients, and the public all goes up drastically when lights and sirens are involved. And so the idea of transporting patients who are exceedingly unlikely to survive, especially for long periods of time with lights and sirens, is a bad one when you look at it from the perspective of the population and large numbers, as opposed to just the single patient that you're taking care of at the moment. We know that quality of CPR is worse in the back of a moving ambulance, not surprisingly. For adults, we can mitigate this somewhat by using mechanical CPR devices, but that's not an option for your 2-year-old. Safety of providers and patients when procedures are being performed in the back of an ambulance goes down. There's some data out there, and I don't know that this is definitive in any way, but some data out there suggesting that families actually cope better with an arrest being terminated on scene. And particularly, as Hillary brought up when she was talking about her approach to that initial case, in some settings, it may be much easier and for certain children. So you know, that family who has a child with a terminal illness and, you know, wants the patient to be in a comfortable, known place, as opposed to the back of an ambulance or an emergency department somewhere, or a hospital somewhere far away, may be much more comfortable with arrest being terminated on scene than a family in some other circumstance. So I don't think any blanket statements can be made, and every situation is going to be different. But transporting that patient away from family members at a time like this isn't something to be taken lightly. And then from a legal perspective, especially if there are longer transports, crossing jurisdictional boundaries is a consideration. And, you know, this isn't something that I want to get super into because I don't think it's the most important thing that we should be considering in taking care of kids. But, you know, if concern for non-accidental trauma or SIDS is part of the equation, you know, taking a patient out of the scene and performing a bunch of interventions when perhaps the child's been unresponsive or was last seen, you know, 4 hours prior and there's asystole with no response. Perhaps it's better for the purposes of investigation for things to be ended on scene, where that investigation can be carried out more thoroughly than for transport to happen. Again, that's something I mentioned sort of peripherally because it's not shouldn't be the primary motivation, I think, in any decision, but it's part of the equation. So those, I think, are some of the downsides to transporting, or I should say routine or, you know, across the board transport. In terms of upsides, you could maybe say that there's the perception that you've done everything possible in transporting the patient, and some parents may take comfort in that. And that's not an unreasonable thing to consider either. I also bring up the question of, you know, could there be better resources in the hospital? In general, I would say that that's not the case for cardiac arrest. Again, BLS care, like high quality CPR, is absolutely the most important component of cardiac arrest. And there are few, if any, ALS interventions that have been proven to improve neurologically intact survival. But there may be some cases where, you know, there are better resources in the hospital, like if there are a limited number of providers on scene, or if there's a limited skill level, or if there are environmental considerations. So there's the possibility that transporting someone to the hospital may allow for additional resources that aren't available on scene, although I openly admit that in the setting where you're able to provide excellent BLS care and those cornerstones of resuscitation on scene, that may not be the case. So I present these to say also that all EMS systems are not the same, and these differences need to be taken into account when making decisions on massive questions like termination of resuscitation or withholding resuscitation on scene. So while guidelines from national and state groups are lacking detail or non-existent, there are some groups that are working on this. This slide was taken from a recent presentation given by Jennifer Anders at the NAEMSP annual meeting a couple months ago, or last month. She discussed in this presentation, and they presented some of their data on their experience, the state of Maryland's experience with developing and implementing a termination of resuscitation protocol for pediatric patients specifically. I'll focus on the medical arrest portion, which you see here, although they do have a traumatic arrest portion too. You'll notice that this includes requirements for duration of resuscitation, for certain interventions which should be performed, for prognostic factors like capnography and presenting rhythm, as well as provisions for the social side of the equation for both family and providers. You'll also notice that it does not include a time cutoff at which transport should be initiated in the absence of ROSC, suggesting a full stay-and-play strategy. They also discuss some of their take-home points from their experience, including involving multiple stakeholders in the development phase and understanding the differences in operational capabilities in different local systems, which I already touched on a little bit. They also emphasized the use of evidence in guiding protocol development, as well as supporting provider judgment in operating within the guidelines or protocol, which is one of those things that I would have loved to have been able to play back from Hillary's initial response, was, you know, allowing providers who have experience and who've done this and who understand the intricacies of the situation that they're working in to use their judgment, which has been developed through experience and over time. So I think all of these are really important considerations. I think more systems developing these protocols and then reporting on their outcomes and experiences will help all of us get to the point where we're making compassionate but intelligent decisions to provide the best care, but also to keep providers safe and keep systems of care from being overutilized, while also being mindful of the emotional challenges of these situations. So in summary, I think data is generally more available for adults than children, but a lot of what I've presented here seems to point in the same direction for a lot of aspects of adult and pediatric cardiac arrest care. We've got room for improvement in developing protocolized care for kids. And I freely admit that I've posed more questions than I've answered this morning. So I will take any questions that you all have, or we can just open it to general discussion.
Feel free to unmute and ask your questions as you would, guys. You don't have to go through the chat if you don't want to. I have a question. Where's the caveats for ECMO? You know, we have kids that are dead in the field, but might be a candidate for ECMO. How would that change things as a pediatric patient?
Yeah, so I think one of the big caveats there is the hypothermic submersion patient. And there are protocols that Dr. Hughes was part of developing, as well as Isabel Szymanski, who I think is on the call this morning, for getting kids transported to primary children's so that ECMO can be initiated for patients that meet certain criteria. Yeah, I think ECMO is an interesting question, Tia, because it's something that I think will probably only be expanded in terms of its uses. It's something that we've been doing here at the U for a while for adult patients. And we have certainly expanded our criteria for adult patients. I can't speak about the details of primaries, of what patients' primaries would consider putting on ECMO, but Hillary can probably chime in and discuss that a little bit more. But I do think that ECMO is something that's only going to be happening more commonly for various patient populations in the hospital, more commonly initiated in the emergency department. And now there are programs working on developing this in the United States for initiation in the pre-hospital setting. And I think in general, ECMO is probably used much more commonly in kids than in adults. And so we may see it proliferate in kids more, but I think getting solid evidence behind who to consider for ECMO and getting appropriate systems of care set up where you've got, the technology and the personnel to initiate it quickly is really important.
Yeah, we use it the most for pediatrics in a hypothermic submersion type or immersion type arrest, but we have considered it. I think we have, we're actually rewriting our ECMO protocol right now. We've broadened, if there's a witness, if a child's in the care of EMS, where we know a medical provider is looking at this child and they arrest, we before would not initiate at all if the arrest occurred in the pre-hospital setting. But now if it's a witness arrest with EMS, I think within 15 minutes of arrival, we're considering.
We have a question. Can you touch on epi infusion versus push dose epi in the ROSC bundle of care?
Ooh, I'm going to answer that honestly. No, I can't, because I haven't seen any really good data telling us which is better. I think there's been a lot of data recently over the last year or two that I've seen about push dose pressors in the pre-hospital setting and how safe or unsafe those may be. And I think people have very different opinions about that. In terms of the question of like bolus dose epi versus infusion of epi, I also don't know that I'm aware of really high quality evidence pointing us in one direction or the other. I will say that for both Salt Lake Fire and Mountain West, we use infusions when you're able to get those set up. And that's one of the things in that bundle that I have our providers doing out at Mountain West is preparing that epi drip and getting it hung so that if blood pressures do start to decline or heart rate does start to decline, you can turn that drip on to maintain those pressures. depending on the system that you're in, it may be more feasible to have push dose pressors ready and just kind of use those as needed, as opposed to preparing a drip. So I'm not aware of really good evidence saying whether push dose versus continuous infusion is better, but Hillary may know better than I do. She knows better than I do in a lot of stuff.
As well. No, I agree. I think in peds the data just doesn't exist because everyone gives push dose for an arrest. That if it's a peri arrest, I think push dose almost like an epi infusion to try to prevent arrest. Or sometimes we'll do it on a kid who we have a large fear will arrest when we intubate them. You know, you have a kid who has a myocarditis or something, and we know that there's a very large chance that when we give them medications to intubate them, they're going to arrest. We'll start a little push dose epi infusion just to try to prevent a cardiac arrest. So there's probably room for it there. But if a kid is already arrested, I don't think there's any data other than full code dose epi being helpful.
And have you seen anything, Hillary, specifically for post-ROSC? Or would you advocate for one or the other, or what would you do in the would you be more, you just have a
we almost always start, and I say we almost always start an epi infusion post-ROSC. I can't remember the last time we didn't. So I think having a push dose available to serve as an epi infusion until you get that kid to a hospital or somewhere where they can get blood or, you know, whatever else it may be is probably a great idea.
Yeah, and I think whether you choose to just have that stick of epi ready and you know what dose you're going to give for a push dose, or whether you can quickly mix up a dirty epi drip and you know how to titrate that appropriately, it's probably sixes. So.
And one other thing I would add just to remember for peds in the post-ROSC bundle is just to make sure we're paying attention to hypothermia. He'll talked about targeted temperature. We don't want to make the child purposely hypothermic to do brain protection, but if they are hypothermic, if we don't get them up to at least a somewhat normal temperature, even 36, that we especially little babies will become bradycardic again. And so keeping that in mind with your post-arrest care is keeping them as warm as you can, I think is a good thing in that bundle.
Yeah, that's a great point. And I'll be honest, I hadn't really considered that for kids specifically, but it makes a ton of sense given how much more prone to hypothermia they are than adults. So
I have another question in the chat. It says, you have said multiple times ALS airway placement doesn't improve outcomes, both in adults and peds. Why do we see ER physicians placing them all the time?
It's a really great question. That's honestly a very fair question to ask. I will say anecdotally that after those three, and this is from providers who work in the adult EDs and are also EMS physicians, after those three trials came out in adults that I referenced, shifted to using supraglottic devices in the ED much more frequently, because I think that's a totally fair question in a lot of cases. It's so quick and so easy to plug a supraglottic device in, and if it's doing the job, and we have fewer concerns with some of these gel-based cuffs like an iGel in terms of decreasing carotid flow or impeding cerebral venous return than we did with the big inflatable balloon supraglottic devices, that they're not only much safer, but they're much easier. And so I think it's a very valid question to ask why we don't routinely place supraglottic devices in ED too, honestly. I don't know, Hillary, do you have an opinion on that?
Yeah, I think and part of it depends on what we think the etiology of the arrest was and how fast this kid's going to turn around. Like if we have a kid who, I don't know, like a lot of seizures, we give Ativan to and they become hypopnic and we end up bagging them. A lot of times on those kids, we try not to intubate. But if you have a kid who maybe had a respiratory arrest from aspiration and you know that their lungs are going to get pretty sick and you're going to get kind of an ARDS type picture and you're going to need really high pressures to support their ventilation. A lot of times we like to have an ET tube where we can really control that cuff pressure and be able to give really high peeps. And so I think that's probably that definitely goes into some of our decision making. And then in peds, we try to get to nutrition pretty fast. So we need to get like an NJ or an NG in pretty quick where we can give nutrition. And sometimes that's a little bit harder with some of the supraglottic devices as well. So that all of that kind of, if it's a kid who's going to be ventilated for a while,
rather than just a short procedure or a fast turnaround. That's part of the reason we'll go to intubation. But we again have that luxury. We have an anesthesiologist as our backup standing right there if we need them. And we have a chest x-ray to ensure that our tube's in the right place. And we have a crite kit at the bedside with a surgeon down the hall if we need it. So we're very spoiled. It's a little bit of a different world.
Well, guys, that is our time. This has been a fantastic presentation and great discussion. If you have not sent me your email, you can right now. But if I have it, please don't send it again, because then we have got a lot of viewers and a lot of emails. I've got a lot of certificates to get out today, and I'm really happy about that. The more, the merrier. Look for those certificates. I should be mailing them out this afternoon. I did see a message from someone saying that they haven't gotten certificates from previous PETOS. I apologize. I don't know why, but you're probably going to find me in your spam blockers. So make sure that you look for this certificate. I mail it out from tdixon@utah.gov. So put me in your safe pile. And Hill, thank you so much. This was fantastic. If anyone else has any additional questions, put them in the chat and I will make sure to forward them to him and he can get in touch with you. Any other questions, last minute thoughts? Don't forget that we're almost complete with our hand heavy purchase, and that is a fantastic guide to help you with your pediatric cardiac arrest. So look forward to using that as a guide in the field as well. And thank you for joining us. I'll stay on for a bit if anyone has any lingering questions. Thank you so much, Hill.
Thanks, Hill. You were wonderful.
Thanks, everyone.
Thanks, Jessica.
This is Becky. Did you get my email?
I did. I saw it come through.
Because I don't know how to do this stuff.
I know. I like that we can reach all sorts of people all over the state, but man, this technology is so over my head. I'm super glad that we can get it out though. That's what we want more than anything.
So I did all of your stuff from last year. I sat and did all of it at home. How do I?
Archives?
Yeah, how do I do that?
Just email me. Email the PETOS. It's utah.petos. No, it's PETOS. utah.petos@gmail. Just email the ones that you have viewed from the archives, and I'll send you the quizzes, and you can just return those.
Okay. Thanks so much, Tia.
Absolutely. Take care. We'll see you next month.
I'm trying not to forget.
I'll try to put out reminders.
I do this, and then I get busy and going like, oh. But it's really good. It's great.
We have some great information, I think, and these docs make a good put together some good presentations. I'm going to make sure I have all my chats saved. I'm going to stop our recording.